Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated.
Good morning, everybody. Welcome to January Grand Rounds. My name's Doug Archibald. I'm the Director of Research for the Department of Family Medicine here at the University of Ottawa, and I'll be moderating today's Grand Rounds session. Typically, at this time, I put on a video, and it is our land acknowledgement. We're going to move away from this mode. The feeling was, as we sort of discussed Grand Rounds, that it was a time that people were using, knowing that they had a minute or two before rounds started, and joining in. And that was not seen as, I think, being respectful or acknowledging the whole purpose of doing a land acknowledgement. So we're now going to encourage, for February Grand Rounds, for our speakers to give a land acknowledgement. I'm going to start today by giving a land acknowledgement. So I'm just going to share my screen here just for a second. Do you all see my screen? Yeah. So, so again, welcome. For my land acknowledgement, I want to say that even though Ottawa is my home, I grew up in Nova Scotia in the Annapolis Valley on the Bay of Fundy. And in Nova Scotia, it's unique. There's only one First Nations in Nova Scotia, and that is the Mi'kmaq people. And the Mi'kmaq, in their traditions, great storytellers, and they would often tell stories. And I'd hear this in school growing up of their god in human form, Glooscap. And he lived on Cape Blomidon, which is this iconic land feature in Nova Scotia on the Bay of Fundy. And these stories would always be about the natural world and how Glooscap interacted with the natural world. So it was always stories about why things are the way they are, why the moon arises every evening, stories of the tides, of how Badger got its stripes, that sort of thing. Today, of course, I work and live in Ottawa, which is the home of the Algonquin and Anishinaabe people. It's unceded territory, meaning that we are guests of this land in which we live and work. I make meaning for this by enjoying the great outdoors, and I'm sharing some photos of Algonquin Park. These are sort of my favorite times where I connect with the land. All this in saying this is my acknowledgement and respect from the land in which we live. So also give some thought to where you are from too, and where you live and work and play. So on that note, I will now move to our speakers at hand. We have two speakers from the Ottawa Hospital, Dr. Anna Wilkinson and Dr. Arun Radhakrishnan. Anna is going to speak first. She's a family physician with a special interest in oncology. She divides her clinical time between caring for medical oncology and patients and academic family practice. Anna is an associate professor, program director for the PGY3 Family Practice Oncology Program, and also the Regional Cancer Primary Care Lead. Anna's passion is bridging the gap between oncology and family medicine with knowledge translation and investigating impacts of cancer screening to optimize cancer outcomes. In her spare time, she tries hard to keep up with her 4 athletic daughters. So Anna, just before I turn it over to you, I do want to mention that Maharan is going to put in a needs assessment for family grand rounds. We want to get your input in terms of how we're doing with family grand rounds. You know, should we be expanding things, etc.? What are some further topics that you'd like to hear about? So please take some time. Click on that link, and when you've got a moment, please fill it in. Anna, over to you.
Thank you so much. I will just share my slides here. Let me just get this going. Okay. Can you see that?
Perfect.
Yep.
We can hear you crystal clear.
Perfect. Okay, I'll get going. So much like you were talking about stories, my presentation today is a bit of a story as well. I think it's the story of prostate cancer screening and where we've come from, where we're going. This is taken from a paper which was published in early December. You may or may not have seen it. It was published in Current Oncology, but related to that, I wrote an op-ed that was in the Globe and Mail, and it was featured on CBC. These are my disclosures. So let's talk about prostate cancer. It's so common. It's 27,000, almost 28,000 cases in Canada in 2024, 22% of all cancers in males, third leading cause of cancer death in Canadian men, 11% of all cancer deaths. And yet, as physicians and family physicians, we're quite conflicted about prostate cancer and prostate cancer screening because the overriding narrative for screening is overdiagnosis. I work a lot in breast cancer. A lot of my research has been in breast cancer. And what struck me and made me start this project was the disconnect. So the numbers in breast cancer are very, very similar, the number of cases, the number of deaths. And yet we know that breast cancer, there's one big difference. There are organized screening programs, and prostate cancer, there really aren't. And as a GP oncologist, I was seeing more and more cases of metastatic prostate cancer on the wards. And so it made me wonder, you know, what's going on here and why don't we screen? And so I went to Statistics Canada and I said, can we look at this? The research that I've done in the past on breast looked at breast cancer screening in women in their 40s, and it used what I call a natural experiment that had been going on. So we knew that in Canada, there were provinces that screened women in their 40s, there were provinces that didn't screen, and we could look at the outcomes to try and get a sense of what was the impact of screening. And so the more I thought about prostate cancer, the more I realized that really there had been another natural experiment going on here that we could look at and use to try and understand this issue a little bit better. And this natural experiment was not geographic, it was temporal, because we've seen changes in prostate cancer screening guidelines that have impacted the way that screening happens. So just a little bit of backdrop as to the story of what's happened with prostate cancer screening over time. So in 1986, the PSA was sort of first thought to be useful, but in the setting of surveillance of people who'd been treated for prostate cancer. The first paper looking at prostate cancer or PSA for prostate cancer screening came out in 1991. And at this point, our task force recommended against screening. The Canadian task force has always recommended against screening. We have never changed our kind of outlook on this, but we've seen many changes in the US. In 1992, the American Cancer Society endorsed screening. We saw the US FDA approve it. And so there was a lot of screening going on. We saw increasing activity during that time. In 2008, the US task force sort of tapped the brakes a little bit and said, you know what, there's insufficient evidence here. We should be cautious. In 2012, they slammed on the brakes and they said, we recommend against screening for all ages. And in 2018, the US actually took a step back and said, you know what, actually, we're not sure, and we're just going to give a neutral recommendation. So why did they change in 2018? They had been tracking their cancer registry, and they saw that since stopping screening, there were increasing rates of aggressive Gleason disease. There was an increase, 36, almost 37% increase in stage 4 prostate cancer and stagnating mortality. So what's been going on in Canada? So as I said, we have never, ever recommended PSA screening in Canada. But the fact that we are neighbors, as we see every day with the US, impacts what happens in Canada. And so we were, in the absence of a recommendation for screening, a lot of people looked to the US for what to be doing. There was variable access across the country. In some provinces, it's funded. In others, it's self-pay. And we know that PSA screening is ongoing. Just because we're saying you shouldn't do it doesn't mean is it happening. Over half of men have had at least one PSA in their life. And we know that since that decision, that slamming on the brakes, we've seen PSA screening drop in Canada as well as the States. But when we're looking at PSA screening, we have to think about it not from the perspective of the 1990s and when it all started. We have to look at it now from the lens of 2025 or 2026. Because we know that PSA screening is not a perfect test. There are very real risks for overdiagnosis. So there's been a lot of measures taken to try and mitigate that concern. So we see PSA testing only happening or only recommended if you have a life expectancy greater than 10 years. We see longer screening intervals. We see repeat PSAs, which drop biopsy rates. The big game changer has been MRIs, which are done pre-biopsy, and that can decrease biopsy rates by about 1/3. We're seeing more targeted biopsies based on MRI results. And what's really important is we're seeing an uncoupling of the concept of overdiagnosis and overtreatment. And so just because you diagnose a prostate cancer doesn't mean you need to treat it. There's the practice is active surveillance for low risk prostate cancers, following them along and making sure they don't become more aggressive and jumping in only when needed. So this is what the Canadian Urological Association recommends for prostate cancer screening. And I like this approach because it actually tries to de-escalate screening. And so if your PSA is less than 1, you only probably need to test every 4 years. And if you are in your 60s and your PSA is less than 1, you can probably stop screening because you will probably never develop a prostate cancer. With a PSA 1 to 3, you probably need to only test every 2 years, and it's only in men with higher PSAs that should be followed more closely. So in the context of that, that's the backdrop for this study. I went to StatsCan and said, can we look at this? I had to go find funding. I put in grant proposals to Prostate Cancer Foundation Canada, to the Sullivan Neurological Foundation, got funds to pay for the analysis to be done. And what we did was a really big study. So it looked at almost over 500,000 prostate cancer cases over 40 years, 150,000 prostate cancer deaths. And we broke the population down into very discrete age bands to try and really look at the nuances of PSA testing and prostate cancer outcomes. We looked at incidence, mortality, stage, net survival. Unfortunately, do not have PSA or Gleason data. It was a multidisciplinary team, so I pulled together not only statistical, but clinical expertise with radoncs, urologists, medoncs, who know a lot about prostate cancer. This study was not a causation study, it was a correlation study. And so we can't draw definitive conclusions, but for sure, this is using big data to try and understand what's been happening. So let's get into what we found. So this is a graph that shows you the incidence of prostate cancer by age group over time. The different colors are different years. And to me, this is super fascinating because 1984 reflects a baseline. There was no PSA. PSA did not exist at that time. And so that blue line in 1984 just shows us the true clinical course of prostate cancer. These would only have been cases which would have clinically presented. And so, when you're worrying about overdiagnosis and cases that never cause a problem, each one of these cases was theoretically not overdiagnosed because they presented clinically. And what we see is that over time, as you age, those case numbers go up and up and up. You'll see with the advent of PSA screening, the different colored lines, we started to bend that curve. And so we see that the age that prostate cancer is diagnosed at has shifted earlier. It's plateaued, and those cases in older men have dropped way down. So we were up over 1,000 cases per 100,000 men in older men before the advent of PSA, and that's dropped almost by half. This is the corresponding change in mortality over time. So the blue line is, again, pre-PSA screening, and you can see over time that curve just keeps dropping. And actually, the largest drop in mortality, relatively speaking, is down in here. It's hard to see because of the scale here, but in the 60s. So looking now at incidence over time, this is a graph which shows you how for men 50 to 74, the rates of prostate cancer changed. And the lines that I've drawn on the vertical lines show the changes with PSA screening. So that black line is the first paper that suggested that we can screen. The green line is when the FDA approved PSA screening. The red line, two red lines are when we sort of tap the brakes and then slam the brakes. And then the black line in 2018 is when the US said, okay, maybe we start again. And I think the first thing we see out of this graph is knowing that Canadian guidelines during this whole period never advised to screen or never recommended screening. Clearly, we're seeing changes in Canada that reflect the guideline changes in the US. The black asterisks down along the bottom there, those represent treatment changes, so major treatment advances. And you'll see that we've got the majority of treatment advances happening after about 2010. But and those treatment advances are at the same time that we see the incidence sort of settle down. So if you were thinking about overdiagnosis, a lot of people look at this graph and say, well, probably this big blip in cases was overdiagnosis because, ordinarily if we didn't have screening, we would have just seen a sort of a straight line and not this big blip. And when we've looked at PSA screening and recommendations for PSA screening, we've looked at this graph typically, so a graph of all men. But let's break it down a bit. So I'm just going to have a... So when you actually break this incidence curves down into 5-year age groups, we see something very different. So we see that in men who are 75 and older, the peak incidence of prostate cancer happened before screening was really widespread. And then the incidence continually dropped thereafter. We do see, however, in men in their late 50s and men in their early and late 60s, these big increases in incidence. And so what this is telling us is that with the advent of screening, we were seeing more cases in younger men and at the same time continually decreasing cases in older men. So this is not what you'd expect when we think about what you hear about prostate cancer. The narrative is you're seeing, cases in older men who have lots of other medical issues and would die of something otherwise. And that's not what we see here. So let's look at the same graph with mortality. Again, this is all men aged 50 to 74. We've got the same time points with the vertical lines. And along the bottom there in those orange boxes, you'll see these are the major changes in prostate cancer treatment. And so this is where having this multidisciplinary team with the rad-oncs, the med-oncs, the urologist was really helpful to pull all this information in. And so many of these changes that we've seen in the last little while are kind of game changers for metastatic disease. So abiraterone and enzalutamide, docetaxel, all of these things. And what we notice, what you can see very clearly, is that mortality dropped really quickly with the advent of PSA screening. And then after the recommendation against screening, it kind of flatlined, despite having all of these treatment advances, many of them very, very expensive drugs at the same time. So again, if we break this down into 5-year age intervals, we see similar patterns. We see in younger men sort of these big drops in mortality and then settling out. We see in older men typically just a continual decline in mortality. When you look at the numbers, about 90% of the mortality reduction for prostate cancer that's happened before we saw that flattening out of mortality. When you dive into what was happening in terms of stage, this is where I think it all becomes very clear, this change in mortality. And so we can only look at stage from 2010 onwards, because this is the first time that we started recording stage in our cancer registry. But if you look at stage by age group, you see that for every single age group of men, and for the whole age group, that the rates of stage 4 cancer over about a 10-year period went up by about 50%. And in men 75 to 79, we see stage 4 rates increasing by 65%. These are not proportions, these are rates. And so these are really significant changes. The last thing we looked at is survival. And what we saw, if you look at survival stage for stage, that has improved. So survival for early stage prostate is really good. It's approaching 100%. The survival for stage 4 prostate cancer increased. Sorry, I'm just going to get rid of that. Increased, and so over time. So all of those treatment advances we saw that were happening were working on an individual case to improve survival. But when you look at survival overall, what we see, or what we saw, was that the actual net survival, which is survival relative or related just to prostate cancer diagnosis, peaked at around the time of PSA screening, and then dropped thereafter. And so we see the survival now is about equivalent to what it was 20 years ago. And the reasoning behind this, when you look at it, seems to be that the proportion of cases has changed. And we have so many more of those stage 4 cases, which even if the survival for each of those cases improve, they are ultimately incurable. And so it impacts on our survival overall. Sorry. So what's the bottom line? This was a large study that used our national cancer data with many, many prostate cancers to audit the impacts of screening guideline changes. It's very clear from the data that what's happening in Canada with our prostate cancer trends reflects the screening recommendations in the US. We saw that after screening became widespread, prostate cancer diagnosis shifted. We saw more cases diagnosed at an earlier age, and then we saw a decrease in men 75 and older. We saw that prostate cancer mortality drop by over 50% after screening started, with the biggest changes noted in men in their 50s and 60s. We saw that after recommendations against screening, that mortality reduction flatlined, and the stage 4 increased in men of all ages. we saw that despite multiple new expensive life-prolonging treatments for patients, which had increased the survival in stage 4 cancer, the overall survival has decreased because of the increasing number of incurable cases. We see that in the absence, well, we know that in the absence of formal screening recommendation in Canada, screening is really opportunistic. And the concern here for me is that opportunistic screening means screening without guardrails. So we are not following those recommendations by the Canadian Urologic Association to de-escalate screening where it doesn't need to happen. We don't have kind of pathways through which MRI definitively happens before diagnosis. We see patients have to self-advocate for screening and self-pay for screening in certain provinces. And so I think this whole study, when you take it all, it makes us think that the narrative that we've always sort of said to our patients, and I know when I have a patient come in and I have to talk about PSA screening with them, I'm very uncomfortable. I never quite know what to say. I think we really have to rethink that overdiagnosis narrative, because clearly, with changes in mortality and changes in incurable cancer, it was impacting cancers which were clinically significant. So happy to take questions.
Many thanks, Anna. Great presentation. Much appreciated. I'll open the floor now. We've got some time for questions.
Hi, Anna. That was a brilliant presentation. And this should be given to the residents, because they are still seeing patients in the office and missing out on opportunities. And sometimes even when people bring it up, they've sort of poo-pooed it because we're working with out-of-date guidelines. I know from talking with Chris Marash and others a few years ago, they were very annoyed that the Canadian guidelines were so anti-PSA. The take-home message was, it'll cause you incontinence and impotence. That was it. Whereas to me, the idea is you may avoid people dying in their 50s and 60s of metastatic prostate cancer. So I really welcome this to be brought to the residents, because sometimes it takes 10 years before people change their approach to things. One of the issues way back when was the PSA cost you $30 25, 30 years ago. And poor people didn't have $30. So I've often felt there was inequity in the whole male versus female cancer management. It's a great presentation. Thank you.
Thanks. And I think what this shows is it's so nuanced, right? It's not, I do agree. Like when I wrote my op-ed in the Globe and Mail, I wrote that, you know, it's almost like threats of incontinence and impotence are threat, you know, that it's muzzling the conversation. Like we don't even start the conversation. And yes, there are risks for overdiagnosis. We do have to be thoughtful about how we use it, but I think we've come a long way in terms of what we do for screening to minimize the impact of overdiagnosis and overtreatment. Tanya.
Yeah, echo the data helps frame our conversations. I guess this is not a research question. It's more of a practicality question. Like, knowing this data now, are you still using that CUA algorithm, or have you changed the way that you present PSA screening to patients?
I'm still figuring out how to present it, because it's very awkward, right? We're in a position where now you have, you know, you're going against what your national guidelines say when you're discussing it with a patient. But I think what this data shows is we really have to rethink this whole issue. That clearly clearly PSA screening was having significant impacts on mortality and early stage diagnosis. So I think when I'm having a discussion with a patient, I talk about these things, and I talk about the fact that yes, it can decrease your risk of dying. I think I talk a lot about how we've changed screening, and so that it's much less likely that we're going to jump in and treat an insignificant cancer, because that, like when we first did PSA screening in the 1990s, we were doing it wrong. We were over-diagnosing, we were over-treating. And so I think what we've seen is kind of a pendulum that swung way away from that, which we were doing it wrong, but I think there are ways to do it more cautiously and more appropriately and still gain the benefits that we see. Am I supposed to pick people, or Doug, are you picking them?
Yeah, go ahead, Anna. Yeah.
I saw Paul's hand up a while ago.
Hi, Anna, thanks very much. Really interesting. And I've always sort of shared decision-making with patients. That's been my approach. Having said that, like too many Ontarians don't have a family doctor, and that's probably going to get worse before it gets better. So where does CCO stand on this?
And again, this is the problem when you don't have an organized screening program and you have opportunistic screening. You can only get it if you need to self-advocate. You have someone who can order it from you. So CCO right now, PSA screening in Ontario is funded if you have a family history. And so absolutely those men should be screened. But other than that, there is no organized screening through CCO. So it's something that I've taken this data back to them, but changes take a long time to happen. And often we need those national changes to happen for our provinces to look at implementing programs.
So if I can, I would highlight what Dave wrote in the chat. This probably needs to get published so that at least family doctors who read the Canadian Family Physician can start implementing some of these recommendations.
It is published. It was published in Current Oncology in December. Yeah. All right. Sorry, I haven't been watching the chat.
I think I'm next. Fantastic work, really interesting. I just had a conversation last week as part of my research studies with a family doc who asked us to prepare digital messaging to all his patients about the update in the cancer guidelines, breast cancer screening guidelines, specifically to address this issue that women 40 to 49 have to self-advocate. And, is he being fair to all his patients and trying to remember to take the time to add that on to have this discussion to inform them that they need to self-advocate if they want breast cancer screening? Or could he try sort of an outreach? There's been an update, go here, find out your risks. And it was just that discussion of him trying to figure out how to do right by his patients when the burden is now on the patients, but then it's also passed on to the family doc, but in a sort of an uneven figure it out as you go, which is the case with a lot of what we do. But it was just the parallels there are with the new breast cancer screening guidelines, which are self-advocate. And that is leaving a lot of family docs uncomfortable, that's not an equal that's not an equal burden across all your patients. And so it's trying to help. One of the things I'm focusing on is trying to help with the communication messages that could go out and what actually works and what might help those who are less likely to self-advocate and maybe level the playing field there. But it's not just the PSA.
I would say that prostate, though, is several steps behind breast because we do have in Ontario now, there is organized screening for women's 40 to 49. So agree that for some reason, CCO is not issuing invite letters to women in their 40s. They start at the 50s. And I think that's, again, because of our national guidelines and the disconnect there. But you can call and book your own mammogram if you're a woman in your 40s. If you're a man in your PS and at any age, you cannot. You have to find a provider, get them to order it, pay it. And so I agree, a lot of it falls down to family docs to do those discussions, but they're very different. Prostate cancer is miles behind breast. And I actually presented this information at a prostate cancer support group. And it was me and a lot of older men, and which was kind of fun for an evening. But really, it's I think a difference in advocacy. There's been a lot of advocacy for breast cancer with breast cancer survivors. And there's not been a lot of advocacy from prostate cancer survivors. And that's why we see the differences that we see. I think Shauna?
Noelle, actually,
we done?
Gotta move on, Anna. Sorry. Thanks. Great conversation, everyone. Shauna, if I could get you to put your question in the chat, that would be great. We're going to move on now to our second presenter, Arun Radhakrishnan, a family physician, focused clinical practice in chronic non-cancer pain. He's an assistant professor with the DFM, an investigator with the Briere Health Research Institute, lead for clinical research at the TOH DFP. He holds a UOttawa Tier 2 Clinical Research Chair in Primary Care for Artificial Intelligence, Innovation, and Implementation. Arun, over to you.
Thank you, Doug. I'm just going to take a moment to share my screen, and before we get going, okay, hopefully we can get that started. Okay, and hopefully everyone can see my screen. We're good?
Perfect.
Awesome. Thank you. So thank you for the kind introduction, Doug. And thank you everyone for being here this morning. So it's my pleasure to share with you our session titled Strengthening Primary Care, and where we'll present some preliminary results from an implementation study of our adaptive mentoring networks. So before we get going, just in terms of disclosures, there we go. My conflicts of interest are that I do get payment from these number of not-for-profit organizations. The payments that I've received are predominantly around developing, evaluating, or studying professional development programs, one of which I'm presenting today. So our objectives for this session are really to describe an implementation practice study, to identify how AI tools can support qualitative data analysis in these studies, and to identify some key consideration in implementing a mentorship network. So just in terms of setting the context, our project that I'm presenting today is part of the Strengthening the Health Workforce for System Transformation program, which is a CIHR team grant that's used to fund implementation studies of innovations that could help to address the health workforce crisis. I won't go too much into the crisis because I think we've heard about this over multiple different sessions in the past. So I think you understand the core issues there. Now, if you want more details about this program itself, the link here will take you to more information about the 15 projects that have been funded through this program. And our Adaptive Mentoring Networks is one of those programs that have been funded, and it's been funded as a multi-site, multi-center study with partnerships at the Memorial University of Newfoundland, University of Toronto, Centre for Effective Practice, and Health Canada. So let's maybe turn our attention to the innovation that we're actually studying, which is the adaptive mentoring networks. And I've had an opportunity to present this in the past to our group here, but in case you don't remember, just a really quick synopsis. So AMNs really are a primary care capacity building innovation that can also have benefits for clinician wellness. Now, currently there are 5 provincial AMNs that are focused on substance use disorders, mental illness, and chronic pain in terms of building capacity. And then there's one national AMN that's focused on health equity, and you can see them over on the map here labeled in black. Now, 2 AMNs are currently decommissioned, and they are in Alberta and Ontario in green. Now, what we see when we look at these 8 AMNs really is an array of networks that have been operating for a different number of years, anywhere from 3 to 20 years, but also networks that are different stages of development. And that gives us an opportunity to really start to think about, okay, well, how have these networks developed and what has worked to help their implementation? And that forms the foundation of our study, which is to take an implementation science approach to develop a scientific framework that can describe how to build these mentorship networks. And so our study is a 3-year study that utilizes mixed methods such as interviews, document analysis, and surveys, and engages participants, including mentors and mentees from these networks, leaders and administrators from these networks, institutional leaders, policymakers, funders, and decision makers at a provincial and national level. Now, if you look over to your right, you'll see a diagram that really characterizes or describes our study in its entirety. In the first column, in the yellow column, I should say, what you're seeing there is a list of the different type or the number of different frameworks from the implementation science world that we're using to guide our project. The project is broken down into 3 phases. So phase 1 is where we work with the existing networks to understand what are the determinants of successful implementation of these networks. In phase 2, we moved to taking those determinants and starting to understand and map them onto what are evidence-based strategies that we can use to build these networks. And in phase 3, we take that strategy or playbook and start to apply them to existing and new networks to help those networks continue their development. Now, across the project, we continue to engage with developmental evaluation to look at the project itself and systems mapping work as well. So I'm going to zoom in a little bit closer to phase 1, which is where we are right now in the study. And phase 1 itself is composed of 3 elements. So phase 1A is looking to understand what are the barriers and facilitators and the implementation activities that are taking place at a program level, right? So at a programmatic system level, what are the things that are preventing or enabling that network from developing? And that work is being conducted at the BHRI. In phase 1B, we turn our attention to the level down, which is examining the capabilities, opportunities, and motivations for mentors and mentees to engage in that mentorship relationship. And that work is taking place at MUN in Newfoundland. Phase 1C is where we start to develop what's called a learning alliance or learning health alliance, which includes leadership from the AMN along with administration, engages system funders, decision makers, and policymakers to look at what we found in phase 1A and 1B, validate that, and help us map that onto established evidence-based strategies. And that work will be taking place at the BHRI. So I'm going to focus down a little further on the study, which is looking at phase 1A, which is what we'll be presenting today. And phase 1A includes all 8 AMNs that we've described and their experiences that represent different actions and experiences from 7 different provinces. And what we've conducted so far are 16 interviews of the leadership and administration across the country. And these interviews were conducted between June and September of 2025. So I want to turn our attention now to the analysis that we're undertaking right now in phase 1A. And so when we look at the analysis, we're looking at using 4 implementation science frameworks. The first is the Consolidated Framework for Implementation Research, where we're zeroing in to understand what are the determinants for successful implementation. The second framework is the Active Implementation Framework, which tries to identify what are those activities that these networks have used in different stages of development to successfully implement. The third construct or framework is the Consolidated Framework for Sustainability Constructs, which tries to understand, well, what are those determinants of a network that lead to sustainability of the network itself? And then the last framework is ERIC, which is Expert Recommendation on Implementation Change, which looks at what are those determinants for successful implementation and trying to map that onto evidence-based strategies to overcome potential barriers that are there. Now, the way we've conducted the analysis is that we have, again, we've got 16 transcripts, and we're taking each transcript and coding them for each framework. Once we've coded the transcripts, we synthesize the transcripts within each network, and then synthesize across all the networks for each framework. Now, once we've completed that work with CIFR, we will then take the synthesized determinants of a network and map that onto evidence-based strategies using ERIC. So, which brings us to our next slide, where I'll start to talk a little bit about qualitative data analysis. Now, as you can see from the previous slide, there's a number of different frameworks that we're using to do our analysis. They are large frameworks, with CIFR being over 67 elements, so an enormous complexity and interplay there, which has created interesting pressures for us in terms of being able to recruit and train personnel to be able to conduct this work and to be able to retain personnel over time. Which then led us to thinking a little bit about, well, how could we perhaps potentially mitigate this challenge? And so we were interested in looking at what artificial intelligence could offer us here. More specifically, we were interested to explore the potential of frontier large language models to address our challenge. Now, a couple of things that went into that consideration includes that if you think about our analysis, it's predominantly deductive analysis. In other words, what we're doing is we're taking the transcripts and we're coding them, categorizing them according to the different frameworks that we've talked about. The second consideration that we took in looking at this is that what we saw in the last year was this emerging capability around large language models, around thinking models. In other words, what these models could do for us now is they could give us the rationale for why they might code a transcript a particular way. And that we haven't seen before. So based on these pieces, we chose to focus on exploring ChatGPT Pro as a model that we would like to help with our data analysis. And so what this did was it led us into diving into the literature to understand, well, what's been written about this? And so when we looked at the literature, there's a lot of rich data and information about how to go about using AI in QDA. But the interesting thing with this is that the data that the studies that we looked at in early 2025, published in early 25, were reporting experiences from 2023, 2024, 2022. And they were using models that were 2.5 years old that don't exist anymore. We can't even find them to use them at this point. So what we did was take what we could learn from the existing literature and design a process of our own that considered the 4 items below. So we wanted to ensure that we were thinking about data privacy and that we were working closely with our local REB, in this case, BHRI, to really think about the pros and cons, the risks and the benefits of AI-based qualitative data analysis. We also recognized that the reliability of AI coding hasn't been established. And so we can't just hand over our transcripts and expect AI to code them, but there has to be a human in the process. The third item we considered was what was going to be the risk of using AI and its impacts on trainees and their skill development, right, in terms of their ability to code and analyze. And so this was part of our considerations. And the fourth piece is that we also recognize that AI is rapidly changing. In the 4 or 5 months that we've been using AI-enabled qualitative data analysis, ChatGPT Pro has had 2 model upgrades, which can have an impact on our prompts themselves. So the process on the right is what we undertook. And it starts with step 1, which is a human-led de-identification of the transcripts, which then moves into step 2, where our researchers and our trainees come together to think about and critically think about how we want to go about asking AI to analyze these transcripts and build a prompt, which is critical in getting AI to execute the actions that we want, and critically iterate that prompt over time to make sure it was executing what we wanted. Once we had the prompt, we would then go into what's called parallel coding, which is step 3, or in other words, human in the loop, where one transcript would be given to AI and to a human. They would code them, come back together, and where there were discrepancies, we moved to step 4, where a human would come to break that or to resolve the discrepancies. Once we coded all the transcripts, we moved into hybrid synthesis, where here what we did was we had AI and 2 human coders take all the transcripts and synthesize them per network. And then once we did that, we then repeated that to synthesize across networks, and we did this for each framework. I'm going to pause here about more details from an AI qualitative data analysis, because I'm hoping to be able to come back and present more about this in a future time. But also additionally, if you're really interested, we will be at ICAM and we'll have a hands-on workshop on this. But if you have questions, please feel free to email us. So now we'll get to presenting our preliminary results. And so for the interest of time, I'm going to focus on just one framework, which is the active implementation framework, or implementation stages is what we focused on. All 8 AMNs and 16 transcripts were included in this analysis. And what this framework, just to remind us, is trying to understand is what activities were undertaken by these networks in each one of these implementation stages. In total, we identified 24 themes, 6 themes in each one of the stages that are listed on the diagram on your right, and with 592 excerpts attached to it. Now, I want you to remember when you're looking at this framework, that this is not a sequential framework, meaning that a program doesn't exit exploration and go to installation, exit installation, go to initial implementation, but rather a program could be undertaking activities in different stages at a given point in time. So it's not linear. So now we'll get to presenting the results, and I'll present them in tables for each stage. So when we look at the exploration phase itself, or the exploration stage, one of the first themes that comes out is a focus on communication and outreach. And again, this is when you're starting to build a program, and it's critical to engage and reach out to critical stakeholders in the community. The second theme that came out was around early funding and really mapping that to resourcing. That when you look at funding at the exploration phase, it's often patchy, it's indeterminate, it's unstable. And so you need to make sure that your resourcing maps onto that appropriately. The third approach is really thinking about how do we look at these networks and how do you adapt them to the local setting? So thinking about it from an equity lens, thinking about local fit and how these networks come together. In the exploration phase, an activity that was undertaken was starting to map out governance. What does governance look like? What does strong governance look like? What are the relationships that we need to build to really establish the legitimacy of a program like this? When we get to the fifth theme, it's around model scanning. So looking at the AMNs that are already out there in the environment, the evidence around them, and how do I take that and adjust the scope to what I'm looking at and then commit to that? And the last piece is around data collection, which is really trying to understand what are the needs for the local community. And then, of course, how do you adjust that to fit local needs? When we get to the second stage, that's installation, you'll see some themes that are repeating from phase one, stage one. Capacity building and training is one thing that you focus on here. So again, building out the capacity for your leadership, for your administration, for your mentors. Identifying funding to enable adoption and to really have some early wins, such as recruiting mentors and mentees. Building critical infrastructure and operational backbones, which includes things like policies, procedures, role definitions. Engaging in data collection, measurement, evaluation, and there's continuous learning loops. Recruitment, selection, and onboarding of mentors and mentees is a critical part of this phase. And then, of course, engaging with your stakeholders to participate in a co-design process, to give constant feedback, and to help in the ongoing planning of these networks. When we look at initial implementation, we see themes of communication, reporting back to stakeholders about what have you done and how is it having an impact on the communities around you, engaging in that continuous improvement cycle, delivering mentorship in a regular process, right? So there's always something, there's a regularity to the meetings and to the sessions, and building that sense of community, that engagement, and that relationship between people. And of course, with data, with data collection, we need to monitor implementation and what are the outcomes of implementation. And then we also need to think about how do you grow these networks in a way that doesn't exceed the resources, both human and financial, that are available. And then when we think about full implementation, what we're looking at is optimizing that growth to fit resource needs. We need to make sure we're aligning the work that's being done with policy priorities and stakeholder needs and articulating that to them, to maintaining that relationship and engagement. We need to maintain quality and fidelity through measurement. That includes ongoing evaluation and evidence generation. And then think about what is the financial and resource sustainability of the networks. So through all of that, that's a lot. That's a lot of themes to take in and a lot of things to consume. So my synthesis of this is really that when you think about these, the themes across the stages, we're really focused on a process of co-design. We're really focused on a process of data-driven networks, collecting data and then adjusting to that data. Strong governance systems that need to be in place that engage stakeholders in co-design. Communication and engagement. So communicating what you're doing both internal to the program, external to the program, selection and training of your staff, leadership, and mentors, and then thinking about funding across the spectrum. Now, if you want to think about this from an application perspective, let's think about new networks in the Department of Medicine and the TOH Department of Family Practice that are under construction right now around mentorship. Now, these networks could take these kinds of tables and identify what are the activities they need to think about when they're about to launch these programs. So in terms of next steps, we are in the process of completing phase one, finishing our analysis, some data collection in 1B. And now we're about to start phase two next week, where we'll have our Learning Health Alliance come together to review the data from phase one and 1B over the next 6 months. And the output is ultimately a playbook that networks can take and figure out how to build these mentorship networks in any domain, in any region across the country. So with that, I'll say I want to express my thanks to the department for the opportunity to present, to all of you for being here, to the organizations that have been funding us and supporting us at the bottom. But I want to give a special thanks to Jane Baselt and Dr. Zach Van Allen for all their work. And I also want to thank our tripartite leadership committee, which includes Dr. Joshua Rash, Douglas Archibald, Samuel Hickox, Christian Rangel, and Jerry Beniette. And then we'll move to questions.
Many thanks, Arun. Great presentation and overview of very complex study. So open the floor to questions. Well, I'll kickstart if you don't mind.
Yes.
When you're looking at something like this, now that I'm seeing this, in presentation, how could we possibly have managed this by hand, like, individually without the assistance of AI? I think of this, when we look at this initial frame that you presented, Arun, and, the fact that there are so many themes within each part of the framework, it also brings up a question of like, how are we going to report this? How are we going to publish this, right? Because when you think about a typical qualitative study, maybe you have up to 5, 6 themes that you are presenting and discussing.
Yeah. It's an excellent question, Doug, and I think a two-parter. So if you think about this, like how could this have been done by hand? It has been done by hand, but what you would require probably in the range of 7 to 8 individuals working on this to code the different frameworks and then to continue to synthesize it, right? And that was the challenge that we faced, was being able to build that capacity here in Ottawa. That was more specifically within our group with the PHRI. That was a challenge that we faced. To the question that you asked around how might we present this data, I think what we have to look at this is an ongoing synthesization, right? So you just so you're starting with the data and you keep synthesizing in layers that continue to move up. When it comes to the implementation stages, I think, it's hard to synthesize less than what we have per stage, but I think what we are going to present are the stages. Where we're going to go to at the end really is that we will have a playbook that really has each stage, and for each stage it will list the activities that programs have undertaken and then list what are the evidence-based strategies that could be used. And that will probably be the final product of the playbook that we'll be looking at. Still voluminous in its nature, but it is trying to synthesize all of those frameworks down to that final playbook.
Thank you. Any other questions, comments?
Arun, Arya here. Excellent presentation. I was wondering if you're planning to submit any grant proposal for this project. Let me know if I could be of any help.
Always happy to work with the ARIA. Right now, the implementation work is funded currently through CIHR, but with the qualitative data analysis piece is sort of an offshoot from the primary project. But that is something we could be looking at submitting some grant funding to explore further.
Super. And what is the nature of transcripts?
So they're interview transcripts. So they are they're based on a interview guide that is based on the frameworks that we have at this time. So it is a dialogue. It's a dialogue between the interviewer and the person being interviewed. So it's a back and forth, a set of questions and answers, and it's a written text.
Okay, and it's a mentor-mentee kind of interactions. Is that?
So we have 2 levels of transcripts. So 1A is looking at transcripts that are interviewing the network leaders and administrators to understand what is the process or the thinking they went through in building the networks. But in the phase 1B, that is where we're asking mentors and mentees more questions about how they went about building that mentoring relationships. What are the things that worked for them? Why did they want to try and pursue this? So that was sort of that phase 1B work that's undergoing right now.
Okay. Very interesting. Good work.
Thank you, Arya.
A lot to consider. And, you know, as you can see, everybody, we're really entering a new foray here of artificial intelligence in terms of assisting as a tool for assisting with data analysis. And certainly very topical. A lot of conversations going on. Just to reiterate again, if you're interested, ICAM, Arun's going to be leading a workshop on these techniques of data analysis. So encourage you to drop into that workshop. We are at time. I'd like to give a huge thank you to Arun and for Anna for two great presentations. Have generated a lot of great discussion, and look forward to seeing you all in February, and wishing you a very successful and prosperous 2026. So until then, have a good day.